Well, as Lee said, my name is Dr. Todd Turner. I specialize in infectious disease. And I want to thank Alan and all the folks at Boulder Neurosurgery for having me here to talk to you today. Let's see. To begin with, I have no relevant commercial interest to disclose. Everything we talk about here today is published guideline-based or FDA approved. I am employed by Boulder Community Health and in their infectious disease department, also known as Beacon Clinic, and I've been there since 2007. So, I'm an infectious disease specialist, so my workday consists of bacterial infections, viral infections, parasitic infections, and these other misshapen protein infections that aren't really alive, but nobody else will claim them, so they're mine. So this is one of those old high school Venn diagrams basically showing where I think the overlap is between my specialty of infectious disease and what you guys do every day. Succinctly, we overlap really for the most part in topics of standard perioperative and post-operative infections, and also in the traumatically induced or intrinsically invasive infections into the central nervous system. Now, this is how I believe most of my surgical colleagues would prefer our Venn diagrams to look like. This is not to imply that they're cold or unappreciative of our assistance. I just think that the need to collaborate with infectious disease on a surgical case is something akin to going to the dentist for a root canal. They understand it's the best course, but it probably means that something unexpected happened when trying to primarily manage the neurosurgical patient. So today, we will start to talk about infections on artificial surfaces, and then I'm going to progress into an approach for fever in the hospitalized neurosurgical patients. I'm a big fan of the audience response system. Here we go. So, 45-year-old male presents at your office with complaints of increasing lumbar back pain over the last 5 days. 3 weeks ago, he underwent a posterior arthrodesis of L3, L4 with a colleague across town. He wishes not to follow up with this surgeon due to some dissatisfaction that occurred during post-operative management. That never happens. The patient is obese with a BMI of 38.4, underlying diabetes managed with insulin injections, active tobacco user for 25 years. Patient relates having subjective fevers and chills for the past 2 days and says that his wife has noted increased focal swelling over the posterior surgical wound, which by this point has healed nicely. The patient also has a history over the past 3 years of 4 visits to urgent care for IND of superficial soft tissue abscesses. No culture data is available. Examination shows the following: mild fever, temp of 38.3, mild tachycardia, respiratory rate of 16, good blood pressure. Exam is significant because he's not toxic in appearance. Mildly tachy but regular. Lung exam was normal. In the skin, he has a raised erythematous warm area over a well-healed midline lumbar incision. It's tender and fluctuant to palpation, no active drainage, and none can be elicited by lateral pressure. You immediately book a time in your local operating theater for surgery. Do you next, A, arrange for your patient to get preoperative IV Cefazolin 1 gram 30 minutes prior, B, preoperative IV Vanco 30 minutes prior, C, Cefazolin on call to the OR for infusion after you get cultures, D, arrange for the above dose of IV Vanco to be on call after cultures are obtained. Do I press a button to start this? All right, great. Well, that's a really good spread. That means it's a good question. If everybody gets it right. Really, my answer here is D, and the reason there's twofold. First of all, Cefazolin, I kind of gave you a trick dose there with 1 gram. That really shouldn't be a perioperative dose at all. With the history, you got this history of having recurrent soft tissue abscesses. That should really lead you to be thinking about a methicillin-resistant subset of Staph aureus. So perhaps this person is an MRSA carrier. So that leads us into next slide, which is management of spinal hardware infections. So These are becoming more and more common over time, and it's mostly due to our aging population and the increase in the sheer number of fusion surgeries that we perform annually in the US. One really eye-opening statistic that I came across said that the total number of spinal fusions increased from about 174,000 in 1998 to 413,000 in 2008. It's quite an increase. And when your average rate of spinal fusion infections is quoted as anywhere between 2 and 5%, that creates a lot of opportunity for hardware infections. So our preferred management of a patient that you may see in your practice, either a surgical follow-up or even in the non-surgical areas in primary care or chiropractic with a recent or even not so recent history of surgery, and you suspect possible infection, I'd like you to kind of follow the following pathway. First, decide if the patient is sick. If they're toxic or demonstrating sepsis criteria, then the rapidity of appropriate antibiotic introduction is of the utmost importance. But if they're not toxic in presentation, we in infectious disease would really prefer that you hold that antibiotic until good deep culture samples can be obtained. Now, if the presenting patient is draining with a sinus wound or purulent fluid in your office, that sample is clearly better than nothing. Once samples are taken, I would then recommend empiric therapy with either vancomycin or daptomycin, with a caveat of maybe adding a gram-negative agent like Zosyn or ertapenem if the patient history or gram stain leads you to suspect this possibility. If you know that this is or likely to be Staph aureus, data would also suggest that you have the possibility of adding oral rifampin to this coverage. I suspect, however, by that point we're going to be involved. So one of the main problems with stabilizing hardware infections is the stabilizing part, meaning that oftentimes the bacteria do not have the good manners or good fortune of waiting for the vertebral levels to fuse before they cause their infection. So the hardware typically must remain. So after we treat with 6 to 8 week course of IV antibiotics, it's recommended in the guidelines that we consider using prolonged oral suppression with an antibiotic directed against the known or suspected pathogens that has good oral bioavailability until fusion has occurred and the hardware can sometimes then be electively removed. So this is my absolutely most favorite slide of the whole day, because I don't want to threaten the reputation of infectious disease specialties, one of the most nerdy of all medical specialties. I included this. These are the underlying mechanisms for why infections on indwelling hardware are such a bigger problem than surgical site infections that do not contain artificial material. There have really been two main proposed mechanisms. The first has to do with the way that white blood cells, namely neutrophils and macrophages, move around the body. Those in the circulatory system are mostly attached to the side of the vessel walls by protein and the glycoproteins that stick up from the surface of the cell. In this way, they slowly roll along the wall in the direction of circulation, but in a speed that's significantly slower than circulation. You that have given steroids have seen the demargination effects and how many of these white blood cells are really up against the vessel wall. So anyway, these neutrophils excuse me, that are happily adhering to the vessel wall get a chemotactic signal that triggers them to move through the vessel wall in a process called diapedesis. And in the tissues, they further migrate towards the infection. This is mediated by sets of these glycoproteins interacting with the fibrin and fibronectin bands, and they approach the offending bacterium and release their toxic granules and accomplish the eradication of the infection. Except, of course, if the hardware infection or the bacterial infection is on hardware. So once that neutrophil gets up to that artificial surface, it can no longer pull itself along, so the response is ineffective. One of my ID mentors when I was training in Washington, D.C., called the whole thing of getting a lot of response to a situation and solving nothing the congressional response. So the second protective mechanism proposed is one of biofilm production. Bacterial colonies will, at times, produce a matrix of something termed extracellular polymeric substance, which the bacterium embeds into. It's been proposed that this may afford protection from both the immune system and antibiotics through the hydrophilic or hydrophobic properties of the substance. My interpretation of the research on biofilms at this point is yes, clearly they do exist, but pharmacies have had, or pharmaceutical companies rather, have had many years to try to develop an effective agent that significantly changes our effectiveness in managing these infections. The fact that this really hasn't made it to market probably shows that the first mechanism up here is really the most important. And really, if you guys are interested in making billions of dollars, if you can really find a substance that fixates fracture lines or fusions that white blood cells can migrate along, I think you have a lot of benefit there. So what happens when our long-term oral suppression fails, which does happen? First off, we'll almost always require another washout of the infected area. Sometimes this alone is enough, but if multiple recurrences of the same infection in the same area associated with hardware happens, it's usually not the fault of the antibiotic, as long as the antibiotic was properly matched to the pathogen in the first place. Often it's the persistence of dead space around the hardware with poor vascularity to the surrounding tissue. This can be overcome sometimes with a muscle or tissue flap to be laid over the infected hardware in question. The other option is a primary exchange of the infected hardware. If the amount of viable bacteria on the primary hardware is just too great to affect suppression, if you make a primary exchange, we don't really expect that second hardware set to be uncontaminated, but perhaps we'll have then a lower bacterial burden and be more easily suppressed by oral antibiotics. All right, the only thing better than really treating a surgical site infection is preventing it from happening in the first place. So how do we do this? Well, the literature comes at this from two main angles. First, we'll mention the controlling surgical risk factors, and then we'll address perioperative antibiotic choices. So these next few slides have portions of a chart taken from guidelines about operative risk factors. Find the risk factors on this portion of the chart probably instructive, but not very helpful. Although you guys are really quite good at what you do and you're highly trained, I'm not aware of how successful you guys are at preventing patients who need surgery from being old, male, obese, or diabetic. Other parts of their medical history are clearly out of our hands as well. So here on this slide are some better factors we may have a little bit of control over. There's the length of surgery greater than 5 hours, posterior approach, the number of levels and instrumentation, the type of implant material used, the use of an allograft. Blood transfusions also are negatively impactful on surgical site infections, probably due to the immunosuppressive effects of the blood transfusion, but also the fact that you're diluting the perioperative antibiotic when you do that. Use of cell savers, microscope, O-arm, C-arm, and open as opposed to minimally invasive surgery, and in any stage surgeries. So here are some post-operative factors that we surely could have some bearing on. First is the aggressive prevention of urinary or fecal incontinence that soil the post-operative dressing and the areas, as well as wound management and the early recognition of cerebrospinal fluid leak. So moving on to the perioperative antibiotic choice. Clearly, we wish to use agents that obtain good tissue levels and are directed towards the majority of bacteria responsible for spinal surgical site infections. Here's a slide breaking down the pathogens reported from a number of reviews. Although these numbers may differ slightly, we see that Staph aureus, both MSSA and MRSA, are the top of all the lists, and Staph epidermidis is number 2. One of the interesting things I find in this list is that the presence of gram-negatives like Pseudomonas, Proteus, E. coli, and Enterobacter are there. I mean, I remember in medical school being told that skin flora is primarily gram-positive, strep and staph. So why is it that these gram-negatives have such a significant minority presence here? Well, two things really. These surgical site infections are probably reported in the perioperative antibiotic era, so a good portion of these gram-negatives in these series either have an intrinsic resistance or a significant number of strains that have resistance to first-generation cephalosporins like ANSEPH. The other explanation is that our simplistic dictum from medical school maybe isn't quite right. There's ongoing characterization of what is normal human bacterial flora, both in the GI tract as well as on the skin. And it's really fascinating to look at the results. In brief, what it shows is there's a high individual difference between people. And there's a sizable proportion of gram-negative colonization on the drier portions of human skin than initially realized. What are the implications for perioperative prophylaxis? Well, I think that research really hasn't made it up the food chain, and I'm not sure there's any recommendations on that. What I would take away from it is that unless you have a known colonization with a resistant gram-positive like MRSA, having gram-negative coverage there with ANSEF is probably important. All right, question number 2. What is the recommended time that cefazolin gets redosed in the operating theater to achieve continuing effective antimicrobial levels in a patient with normal elimination and metabolic function? Is it A, 4 hours, B, 6 hours, C, 8 hours, or no need to redose? All right, another good spread. So the correct answer here is A, it's 4 hours. So this is a pretty inclusive list of some perioperative antibiotics. Just a couple of points to make here. First is the difference between the redosing recommendations intraoperatively for these antibiotics and compared to how we dose them therapeutically. For example, ANSEF or cefazolin, when we treat an infection, we dose it every 8 hours. But here it's recommended to be dosed at hour 4. Aztreonam is the same way. It's normally Q8 in treatment, but here it's redosed as 4. Same idea, but different numbers for Unison and ampicillin alone. What these recommendations are trying to do is they're trying to maintain tissue concentration of these antibiotics above the MIC for most pathogens. It's a mean inhibitory concentration during the entire table time. As most of these antibiotics that we use here are what we call time-dependent killers of microbes, as opposed to concentration-dependent antibiotics, it makes pharmacokinetic sense. Time-dependent antimicrobials, they do their dirty work when their levels are above the MIC and only during that time that they are. So the second point here to pay close attention to is cefazolin. There is no 1 gram dose recommended perioperatively. 2 grams for all patients, and in patients over 120 kilograms, 3 grams. You'll never see us use that dose in therapy. So these are stragglers on the end from the last slide. Vancomycin really here is the one that you guys deal the most with. Notice that perioperatively this is a weight-based dose of 15 milligrams per kilogram. You know, that works out for the standard 1 gram, right? For people 67 kilograms or less, non-metric folks in the audience, it's 145 pounds. So bigger people need bigger doses. A 200-pound person would need between 1.25 grams and 1.5 grams. 2 gram doses should be considered for patients whose weight goes closer to 130 kilograms or near 300 pounds. All right, shifting gears to fever in the neurosurgical patient. Intracranial folks, I didn't forget you. You guys might get a little less time on this, but you get more questions. Fever in the neurosurgical patient. The reported incidence of post-operative infection in neurosurgical patients is between 1% and 8%, depending on the series. And fever is a significant indicator of this. So this process is very important. In my mind, it's made up of 3 questions. First, what defines a fever in a neurosurgical patient? Next, is it infectious or non-infectious? And third, are there any clinical clues as to the cause? So this probably brings up a more straightforward question. What is the accepted and correct definition of a fever? Is it A, a single temperature greater than 38? Is it B, 2 consecutive temperature measurements greater than 38.3? Is it C, a single temperature greater or equal to 38.3 or greater than 38 for more than an hour? Or D, it depends on who you ask. Great. So yeah, the answer here for me is D. It depends on who you ask. Usually it's not the pithy, sarcastic answer at the end, but this time it is. So the definition we're all familiar with is the single temperature above 38 degrees Celsius, but these other 2 are valid as well. The point here is that body temperature raises on a continuum due to inflammation, and there has to be a point at which the temperature or trend concerns us enough as clinicians to look at it more closely. Recall that healthy people have sinusoidal variation in temperature on a daily basis, and that a sick or post-operative patient can have any number of processes going on both infectious and non-infectious, that cause cytokine level disruptions that produce temperature spikes and elevations. So it doesn't matter technically the definition so much. If you call me and say, my patient has a fever of 37.2, I might not be so impressed. But if you call me and say, look, they're 37.9 and they're not acting right and they just seem off to me, I will pay attention in that patient. So let's go with another question. Of the following symptoms, which is the most common with deep infections post-craniotomy? Is it A, fever, B, headache, C, seizure, or D, mental status change? Great. So you guys are spot on. It's mental status change. So fever is not really the most commonly reported symptom of intracranial postoperative infections. All right, so let's look at fevers by going over their causes, split between infectious and non-infectious etiologies. On the left side here, we see a list of all of our favorite healthcare-associated infections, followed by some specific causes of infections in patients who've had their skulls opened. On the right is an equally large list of all the things that can cause fever in the hospitalized patient that have absolutely nothing to do with infections. Well, this here is perhaps the most important slide in this section. How do you work up a fever or a suspicion for infection without fever once you have determined that it cannot be ignored? These make up a list of musts, unless of course the cause is immediately evident and discoverable. But these things should be obtained if you're still in a quest to determine the cause of fevers. It's a full physical examination, evaluation of all lines and tubes in a patient, CBC and CMP, at least 2 sets of blood cultures, urine cultures, stool studies if there's diarrhea involved, chest x-ray, imaging of areas of interest, like a head CT or an MRI in a post-craniotomy patient when indicated. Of the infectious complications in a neurosurgical patient, none is more difficult to specifically diagnose than postoperative meningitis. Merely by violating the meninges and working in the central nervous system, there's apt to be some mild pleocytosis in blood in the CSF as a matter of course. And this postoperative reactive inflammation is probably the cause of most cases of aseptic meningitis. The ratio of prevalence shows there are 3 times as many aseptic meningitis cases postoperatively than bacterial causes. However, the symptoms cannot be distinguished. There exists some data that says that the CSF white blood cell counts trend higher in cases of bacterial infection, but the overlap does not allow this to be entirely differentiating. When you know how difficult it is to distinguish between true bacterial infection and aseptic inflammation, but then you throw in the mortality rate for bacterial meningitis postoperatively is 20%, it's really easy to see why we're also quick to use empiric antibiotic coverage while the cerebrospinal fluid cultures are pending. So what about bone flap infections or abscess? Well, these usually onset later when they occur in isolation. Please keep in mind that it's altogether reasonable and possible for a bone flap infection with an abscess or empyema to seed the cerebrospinal fluid and cause bacterial meningitis. But for the sake of this lecture and simplicity, we're going to address these as separate entities. In the case of bone flap infections, and especially overlying abscess, you really need to look for drainage to the surface, wound breakdown, and skin findings. Situations are reliably sorted out in imaging most of the time, and almost always require surgical reintervention for washout or even removal of the bone flap. So this is from the IDSA, the Infectious Disease Society of America, recommendations for the management of bacterial meningitis. These recommendations are due for a revision this year or next, but they're still quite applicable. Notice that all the penetrating trauma and post-neurosurgery, as well as the cerebrospinal fluid shunt placement recommendations are identical. Vancomycin plus cefepime or ceftazidime or miraparin. It's always good to know what we're aiming at. These are the prevalence of specific bacterial isolates in 21 cases of postoperative bacterial meningitis from 2007. We can see that although this is a small series, we're used to that in ID, About 40% were staph, most being Staph aureus. About 30% were respiratory colonizers. I'm unsure how this relates to the surgical approach. One could imagine a transsphenoidal approach carries an increased risk of those strains. A good third of these cases were gram-negatives, and then remind me to, remind you of the point made earlier about gram-negatives being an under-recognized normal flora, even on skin at the scalp and neck. All right, question 5. 64-year-old female who is 10 days status post to 2-level arthrodesis has been recovering at home after a quite uneventful short inpatient post-op stay. She presents urgently at your office with a new onset fever and rash, which began yesterday, post-op day 9. The fever is unremitting at 39 degrees Celsius, although she reports that she feels terrible with significant muscle and joint pain. You notice she looks relatively non-toxic for her reported office temp of 39.4. She takes daily Lipitor, lisinopril. She also occasionally is put on Lasix when she accumulates lower extremity edema, but has not taken these, or the Lasix at least, for many weeks. She did start taking a medication given to her by her primary care physician over a year ago, just in case she developed UTI symptoms. She did this after noticing mild dysuria onset 2 days ago. She's taking this medication twice a day for 3 days, but cannot recall its name. Anyway, she's taken this medication before in the past without any problem, she tells me. Examination's non-focal, incisions well healing without fluctuance or drainage. She does have a broadly distributed maculopapular rash with some mild focal urticarial areas over the trunk. What is your next move? Do A, draw blood cultures, 2 sets, and start empiric Keflex and Doxy in addition to whatever she's taking from her primary care physician, as you're concerned about infection from skin flora at her surgical site. Do B, draw blood and urine cultures in a CBC, obtain a urinalysis, discontinue her urinary tract infection therapy, and have her return in 72 hours for a revisit? Do you C, send her to the ER for evaluation and admission because fevers above 39 signify a deteriorating situation. She needs empiric parenteral antibiotics and a fever workup with imaging? Or D, I'm calling you, Dr. Turner, that's your time. Great, good spread again. But the correct answer here, and I think the majority of you got this, is B. This is a perfect question to really drive home my final point on fevers, is do not forget to review the patient's drug list. This patient was presumably taking Bactrim given her, which is a sulfate drug, the most common drug responsible for allergies and fever in the general population. Drug fever is very common both as inpatients and outpatients, and this slide lists some typical drug causes on the left. The clues on this are high fevers that don't seem to have a break or a diurnal rhythm to. The second is that these patients don't really appear as toxic, although they have a lot of complaints. Oftentimes a rash, and there is in the literature reported a temperature heart rate mismatch, but I'm not really convinced that that's a truism. All right, this last slide is just a couple of guidelines referenced in this lecture. Thank you very much for your attention. If there's time, I can take a question.